My name is Dr. Jeremy London. I am a board-certified cardiovascular surgeon, and I've been in clinical practice for the last 25 years. Today's episode is going to be an exploration into what you can expect after heart surgery. Specifically, two procedures, and I've chosen these because they're very common, and you're likely to come in contact with these exposures either with yourself, friend, or family member, because they are probably the two most common procedures done worldwide, starting with a more minimally invasive procedure, the cardiac catheterization and potential stenting, moving to a more invasive procedure of formal open heart surgery. And we'll break down the discussion in the following way. First, we'll talk about the procedures themselves, just so that we're all on the same page. Next, we'll talk about the physical recovery from these procedures, followed by the emotional and mental response that many patients have to these procedures. And finally, what it's like to navigate a chronic illness. Who do I think will benefit the most from this conversation? Well, obviously, if you're headed towards one of these procedures, have experienced the procedure itself, and if you're a family member, friend, or part of a support mechanism for an individual that is in that situation, and we'll talk about why that's so important. So really, I think this applies to most of us. So let's start with cardiac catheterization and stenting. Well, first of all, what is that? Well, it's a minimally invasive procedure, meaning it doesn't make a large incision, but the body is entered either through the wrist in the radial artery or through the groin in the femoral artery. It's done just under local anesthesia with IV sedation, kind of like having a big dental procedure done. You're going to know something's happening, but you're really not going to care. Of note, I have had a cardiac catheterization with a stent, and given my personal issues, I refused the sedation initially. However, as the procedure became more complicated and I became overly involved as a patient, the sedation was administered, and the cardiologist was able to continue the procedure without me interrupting him. So I highly recommend that you follow the instructions of the physician so that the procedure can proceed smoothly. The whole procedure takes about an hour to an hour and a half, and it depends on the complexity of the procedure that they have to do. But it involves, again, accessing either in the wrist or in the groin, and a small catheter is then directed through the extremity, either the arm or the leg, to the main blood vessel, the aorta, and then to the heart, and engages into the two main heart arteries. You have a left main artery and a right coronary artery. And then contrast dye is injected into those arteries, and under X-ray guidance, you can see a physical roadmap of where the blockages are. And then procedures can then be performed, directed again by the X-ray and the dye, where a wire is passed across the blockage, and then a stent, which kind of looks like the old Chinese finger traps made of metal, but they're very small, anywhere from 2 millimeters up to about 3.5 millimeters, crimped onto a small balloon. That is then passed across the blockage. Once it's confirmed in place, again, by repeating that roadmap, you can make sure that the stent is in the correct position. The balloon is inflated. That expands the blockage. The balloon is deflated, and the rigid metal stent is left in place, then reestablishing blood flow in the heart arteries so that the heart muscle below that blockage that was blood-starved now has reestablished flow to receive nutrients and oxygen. So that's basically how it works. As far as the immediate discomfort that you have, it's minimal. The wrist may be a little sore, the groin may be a little sore, you may get some bruising, but the amount of invasiveness or the magnitude of the operation is quite minimal given the significant benefits that patients get as a result of opening these heart arteries. You typically stay in the hospital overnight. Some cardiologists will let their patients go home late in the day if they're done early in the morning, but that is unusual. Typically, people that have patients that have stents placed are kept overnight to make sure that heart rhythm remains stable, that their medications are where they need to be, that there's no complication at the insertion site, be it in the artery in the wrist or in the groin, before going home. We'll get back to the podcast in just a minute. I'd like to thank today's sponsor, Momentous. Now, remember that muscle is the organ of longevity. And as we age, we lose muscle. After the age of 30, it's about 8% every decade. So what I like to do is I like to supplement my daily smoothies with both protein and creatine. And this, with a consistent resistance training program, gives me the best results. Now remember that these are supplements, not substitutions for a whole foods diet. So think about what you put in your mouth. Now, my family and I have been using these products for years, and we absolutely love them. And the reason is because they are third-party tested, NSF certified, and quality sourced. If you're interested in trying these, check them out at www.livemomentous.com/London for up to a 35% discount. That's www.livemomentous.com/London for a discount. Now let's get back to the podcast. Once you're home, the physical limitations are minor, given the minor procedure that you've had. Although the artery has been entered either in the wrist or the groin, so you do have to be careful with lifting, or driving. Typically, if the groin has been accessed for several days, some cardiologists ask that you don't drive for a week, and that you can basically go through life normally as far as activities of daily living, but you keep your level of exertion to a reasonable amount. You can go for walks, you can take care of your children, and carry the laundry if it's not too heavy and things of that nature. But you do have to be mindful that you have had an entry point in the artery, and that does need to heal. Beyond that point, your recovery happens very, very quickly. As far as any discomfort and the hopes, if you are having symptoms as a result of the blockage, of course, that those things would continually get better. So that's the basic process of cardiac catheterization and what you can expect from a physical standpoint and physical limitations after the procedure. Now, moving on into more invasive type procedures, formal open heart surgery or cardiac surgery is significantly more invasive. Now, there is a range as far as the incisions that we utilize to access various parts of the heart. The standard incision is what's referred to as the median sternotomy, or the zipper club, if you will, the incision down the middle of the breastbone. Many patients say, "You're going to bust my chest wide open." No, we make a gentle incision in the sternum to get to the various cardiac structures. But there are also minimally invasive approaches that we utilize through small incisions in the right upper chest, on the left side to access the bypass operations. But for the purposes of this discussion, because the median sternotomy or midline incision is the most common, we're going to focus on that particular access because that's where a lot of the physical limitations after heart surgery are based from. So open heart surgery can encompass many different things. It can encompass bypass surgery for blockages. It can encompass valve replacement. It can encompass transplant. The incision is the same. For the purposes of this discussion, we'll really focus again on the treatment of blockages because that is, in fact, what is most common and what you're most likely to come in contact with. So the operation itself involves an incision down the middle of the breastbone and a couple of small incisions in the leg, one in the groin and one at the knee. And the reason for this is you have to obtain the tubes or conduit to perform the bypasses. As the most common places are the leg, the saphenous vein, and the radial artery in the arm. We have two arteries in the arm that supply the hand, and one of them can be removed in most people. And these harvest or removal of these things are done in a minimally invasive fashion. We no longer make long incisions to remove these. It's through very small incisions and with a scope. Now, you say, well, you're going to remove a vein in my leg. Is that bad? Removing the vein in the leg is a secondary vein. It's not the main venous drainage of the leg. It's the same vein that is stripped in a vein stripping if you have varicose veins. So you can live without what's referred to as the greater saphenous vein without any problem, but you can have a little bit of swelling in the extremity afterwards. But it's small incisions in the leg or small incisions in the arm. The artery from behind the breastbone, the internal mammary artery, is then harvested as the other source of the tubes. And then the heart-lung machine is utilized in the majority of these operations. It can be done with or without the cardiopulmonary bypass or heart-lung machine. The advantage to the heart-lung machine is the heart can be stopped and the operation can be done on a very still heart. But the procedure can also be done in a beating heart fashion without the heart-lung machine. Why is that important? Well, the heart-lung machine, which basically supports the body during the heart operation. So it takes deoxygenated blood back to a machine, it's oxygenated and then put back in the main blood vessel to support the body while the heart is actually stopped and the operation is done. Well, clearly, that's not a normal way for blood to go around the body. So there's an advantage to allowing the heart beating to maintain normal blood flow throughout. But interestingly, even in large series, the complications and outcomes have pretty much been equivalent between those two, and so it becomes surgeon preference which operation they prefer. The whole procedure takes anywhere from 3.5 to potentially 6 hours, again, just depending on the complexity of the operation. You typically spend a night or two in an intensive care unit, a short period of time with the breathing tube, and then 5 to 7 days in the hospital total, including the time in the intensive care unit after surgery. Now, unlike cardiac catheterization, which is minimally invasive through small incisions, this is maximally invasive through a large incision, and the first 24 to 36 hours is rough. It is uncomfortable. You are given pain medicines. What we do in our hospital is patients are given the PCA, or patient-controlled analgesia, where we give a continuous infusion of medication, and then the patient can get additional doses as they need on an appropriate limited fashion. But that first 24 to 36 hours can be really rough. Interestingly, after that, it gets better very quickly. And the reason for this is the closure is very stable, unlike an abdominal incision where you can have a lot of muscular spasm that can be very painful. You don't really have that with the chest, with a sternotomy or chest incision, even though there are some muscles that you're going in between the chest muscles. We don't really split those muscles, so there's not a lot of spasm associated with it. So typically speaking, once patients get out beyond that first 24 to 36 hours, it's uncomfortable but not unbearable. In addition, patients with heart surgery have chest tubes, which are tubes varying in size anywhere from about my thumb in circumference to maybe my ring finger or your ring finger size in circumference. The reason that those are in place is because after heart surgery, it's similar to having a burn on the skin. There's an inflammatory process. You know, when you get that kind of tacky fluid with a burn or a bad abrasion, there's a lot of inflammatory changes that go on within the chest as a result of the trauma of us being there. And we want that fluid to, of course, drain off over the course of the several days after surgery. In addition, it's our window into what's going on after a big heart operation, and in those initial hours, if there were to be any significant bleeding, we would be able to identify that and take patients back to the operating room. That being said, the chest tubes are uncomfortable. So every time patients take a deep breath, cough, or sneeze, they typically complain that they hurt quite a bit. Those stay in anywhere from 3 days to 5 days. From that point, you are then transferred typically out of the intensive care unit, and you spend another few days out on a step-down unit or some sort of transitional unit where you're continually monitored. What determines if you go home at 5 days or 7 days? Well, again, it's this physical recovery that's important. Well, what does that mean specifically? Well, you have to be able to take care of yourself. What does that mean? That means getting out of bed without assistance, getting to the bathroom. Once you're home, getting to the kitchen, getting to the telephone. You may have to be left for a period of time, and whoever's staying with you or caring for you needs to feel comfortable that you can do those basic things before you're discharged home. So those basic physical tasks have to be in place before you're sent home. Once home, you are not confined to your recliner or the sofa or the bed. We want patients up and moving every day, bearing in mind that there are two basic restrictions for the first month. One is no heavy lifting greater than 5 to 10 pounds, and the other is no driving for 1 month. The reason for the driving limitation is twofold. One, obviously a frontal impact with a fresh incision in the sternum would be devastating. The second is the patient's potentially had a big anesthetic and is continuing to take pain pills, and reaction time will be delayed. God forbid a child were to ride a bike in front of the car. That would change everybody's life forever. So we ask that patients don't drive for 1 month. But during that period of time, we want patients up and active and moving every day, specifically walking. Walking 40 minutes a day is the minimum that we are looking for. Now, it doesn't all have to be at one time. And in the beginning, you're not going to feel really strong after a big operation like this. So the last thing we want you to do is head out your front door, get a quarter mile from your house, and you can't get back because you're short of breath or just too worn out. What are the options? Place a chair next to a treadmill, walk on the treadmill until you get fatigued, get off and rest, catch your breath, get back on the treadmill for a total walking time of about 40 minutes, or place a chair outside your front door and just walk around your house, and you can effectively do the same thing. Once you gain some confidence, you can then head out and walk without stopping or find benches to sit on or what have you, with the confidence that you'll be able to get back home without any issue. As far as the discomfort level, it gets better very quickly. How much can you lift? How much should you lift? Well, you can slowly increase that 5 to 10 pound restriction once you hit the 3 or 4 week mark. Some of the specific activities that people want to know about are playing golf or shooting a shotgun or a gun if they're hunters. I allow people to chip and putt at 6 weeks, full swing at 3 months. Same with shooting a gun. You really have to wait the full 3 months for the sternum to be totally healed before you can do those kinds of activities. At 6 weeks, you are placed in cardiac rehab, which is a supervised exercise program. And the advantage to going to a supervised exercise program is that you'll be placed on a treadmill or an exercise bike with blood pressure cuff, checking your pulse and your oxygen levels. And what it does effectively is it helps you develop a yardstick. Am I doing too much or not enough at home, where you're being monitored very closely? In addition, you get to interact with other individuals that have had similar procedures, and that commiseration sometimes can be very worthwhile. At 8 weeks, you're really getting your land legs back. You don't really have the good day, bad day anymore. You're feeling strong again. You're feeling the results of the bypass surgery are in place. If you've had shortness of breath with activity or you were having chest pain, typically that is gone. And by 3 months, once again, the breastbone is totally healed and you have absolutely no restrictions at that point. We'll get back to the podcast in a minute. I want to thank our sponsor, The Farmer's Dog. Our family makes an effort to eat nutrient-dense whole foods, limiting ultra-processed foods as much as possible. With proper nutrition, we feel better, and we have more energy throughout the day. We believe our dogs deserve the same. Farmer's Dog doesn't sacrifice convenience for quality. Their food is human grade, made from whole meats and vegetables. Our dogs have been eating Farmer's Dog for the past 3 years and absolutely love it. Each plan is personalized, ensuring adequate portion size, recipes, and total calories. Farmer's Dog makes feeding healthy simple and easy. So when life gets busy, your dog's nutrition doesn't take a back seat. If you want to experience how much your dogs will love eating healthy, visit www.thefarmersdog.com/London to get 50% off your first order. That's www.thefarmersdog.com/London to enjoy 50% off. Now, let's get back to the podcast. So I think that gives you a perspective of the individual procedures from a more minimally invasive approach to a more invasive approach, as well as what the physical recovery requires, as you would expect, much more with open heart surgery than it is with stenting. Where there's some intersection of the crossroads of recovery is in the emotional and mental response that many patients have after undergoing procedures like this. Depression and anxiety are not uncommon, particularly after open heart surgery, mainly I think because of the magnitude of it, and it really is just an overwhelming experience, but it certainly happens with cardiac catheterization as well. It can be really emotional. For me personally, I spent about 36 hours prior to my catheterization knowing that there was something wrong, but I didn't respond to it in an appropriate way quickly enough. And then when the symptoms came on full force, I knew I really had to respond. And I was taken to the catheterization suite, which was where they performed this procedure, and underwent the procedure. And it was a higher risk type procedure that I was uncomfortable during the procedure and realized what was going on. And literally, this occurred on a Monday, and everything went great. The procedure went great. I had no complications, and I was taken back up to my room where my wife stayed with me overnight. And I'll never forget the feeling of waking up. Well, I probably didn't sleep much in the hospital bed, but getting out of bed the next morning and consciously realizing that all of my priorities had been shifted. Like things that were really important to me 48 hours previously, the majority of them weren't even on the list. The things that were really important to me were my family, my friends, and the people I care about. Because when you are slapped with this harsh reality, your whole world gets flipped upside down, and you realize that your mortality is real and that we all have to face that at some point, and that I have been given this opportunity to recognize that, and literally my priorities just absolutely transformed. And it changed the course of how I looked at my life day to day from that point. And honestly, it's one of the main motivations for doing this, for creating content for podcasts and for all the various platforms, because I feel like I want to share my experience, because I think that I have a unique perspective, both as a physician and now 2.5, almost 3 years out as a patient as well. I truly understand what it means to go through this, and being able to share that in an exponential fashion has really been very powerful for me personally, and very satisfying professionally, because for years I've been able to take care of one patient at a time, be it in my office or in the operating room. But that's not a scalable model. I only can interact with one patient. I've only got 2 hands to be able to operate, but this has enabled me to reach so many people. And because I think this entire experience was so powerful and emotional for me, it has absolutely been one of the primary motivations, not just to share my experience, but also to share information that'll hopefully allow you to make changes or continue to do the things you do to stay off my operating room table. I mentioned that my wife had stayed with me in the hospital, which I certainly appreciated. And it just brings up the importance of support and support structure for individuals that are going through cardiac procedures in particular. One of the things that I have recognized over the years is patients that have individuals that care about them do better than patients that don't have anybody. It's really sad when patients have to recover from big operations like this and they don't have anybody. And there's a clear difference in the way people recover and way patients recover when they have a support mechanism in place. It's so important to me that I typically won't have a preoperative conversation without a friend, family member, available to be a part of that conversation, either in person or by telephone, really for 2 reasons. Because if we're having bumps in the road with a procedure, because these are big operations that I do, I'm rarely having a conversation with the patient. I'm having a conversation with the family members. So I want them there so they have an expectation of what's to come. But more importantly, or as importantly, they need to know what the recovery process is so that they can understand what it takes to help support somebody through this type of process. And so having a support mechanism in place, whether you're the patient, a potential patient listening to this, or you're just a friend or a family member of someone that's going to be going through this, you play an integral part in the recovery of patients after cardiac procedures. So I think when you really distill this aspect of recovery down, this emotional, mental recovery, it's really based foundationally on this idea of now I have to live with this diagnosis of a chronic disease. And that's hard to hear. Wherever you are on the spectrum, it's hard to hear and it's hard to navigate. And I think that's really what puts the emotion behind a lot of this. And when you've had these procedures, it's really a second golden ring many times. Now, obviously, they're not all perfect outcomes and all where we want patients to be. It's people operating on people, and the outcomes are not always predictable. But for the most part, the success of stenting and open heart surgery and bypass surgery for the right patients has very, very good outcomes. And so I really felt like I had a second golden ring when I woke up on that Tuesday morning. And I think many patients do, but their question is related again to this Now what do I do? And then it becomes, am I going to be able to live a normal life? Am I going to be normal after I've had all of this done? I remember when I was in practice, maybe 4 or 5 years after I had come to town, and my wife and I, we were huge into endurance sports, and we were big runners. In fact, recently we were out for a run, and she looked at me and she said, "We need to get shirts made." And I said, "Yeah, what's that?" She said, "We used to be fast." I was like, "Thanks a lot." So years ago, when I used to be faster, I've never been fast, I was running a half marathon in town, and I was on track for a personal record in this race. And I'm running, I'm lined up for a 1:44 half marathon, feeling good about myself. And around the last, I was probably at mile, probably 11, 10 and a half, 11. And I hear someone behind me screaming, "Dr. London, Dr. London, Dr. London." And I can't see him. And I feel someone just slap me on the behind and run past me. And it was a guy that I had done an aortic valve replacement on about 2 years prior. And he passed me during a half marathon. He ran a 1:39 half marathon, and I ran a 1:44:30 half marathon. Beat me. Now, this is an extreme case, obviously, an outlier, but it really made me feel good to see somebody recover to that level and be able to perform in that way. And certainly the majority of the folks that I operate on are not that young, and they're not out running half marathons. But as far as getting your life back, the short answer is yes, for the most part. And I think that we're all faced with choices when we are given the diagnosis of some chronic disease state. We can give up, or we can take responsibility. And in the case of heart disease, taking responsibility really is focusing on the major levers of health span and lifespan, which are focusing on a whole foods diet, a consistent exercise program that involves both aerobic and resistance training, because VO2 max, or the cardiovascular efficiency quotient, is a very powerful indicator of longevity, and staying strong and maintaining your muscle mass is absolutely critical for our lifespan. In addition, a solid sleep and recovery program, as well as a solid social and family spiritual framework. Those are the basic levers. So we know those levers. So what's the next step? Well, the idea is that you examine your life as a result of these diagnoses with some intellectual honesty, like shine the light in the corners. What levers are you good at? Which levers are you not so good at? For me, I was absolutely a fanatic about diet and exercise, and I thought I had everything dialed in, and I still ended up with a stent in my right coronary artery. And I could have said, "Oh, why did I spend all that time doing that? I should just be smoking cigarettes and drinking alcohol and just laying back." Or you say, think where I would be if I hadn't done all of those things, and now what can I do better? And by identifying which levers you're good at, and more importantly, which aspects you're not good at. My weakness is sleep and recovery. From 25 years of being in practice, I'm always on DEFCON 1. I'm always ready to answer my phone. The slightest noise in the middle of the night, I'm up. I never really go all the way to sleep. And I struggle with sleep and recovery. In addition, I looked more closely at my diet that I felt like I had really fine-tuned. And I placed a continuous glucose monitor for a period of time and realized that I was pre-diabetic, and changed my diet accordingly so that I could then move that needle for all of the levers that I felt like I had control of to then improve my long-term survival. Because what you have to realize, whether you're having bypass surgery or you're being stented, neither of those things are treating the underlying cause of the problem, which is the hardening of the arteries. And that process continues after you've had these procedures. So if you're not making these changes, then the longevity of those procedures and the durability of those procedures are potentially much less. Now look, we can't run from our genes. We're stuck with who we are. But we can affect how our genes are expressed. So it's really important to consciously and intentionally create your own personal instruction manual for a successful program for maximizing your health span as well as your longevity. I hope you've enjoyed the podcast today. Thank you so much for listening. If you or someone that you care about might be going through one of these procedures, please share this podcast if you feel like they may benefit. If you're watching on YouTube, please like and subscribe. If you're listening on Apple Podcast or Spotify, you can leave up to a 5-star rating. We would greatly appreciate it. I hope you guys have a great day.